Good evening, everyone. Today is Sunday, November 20th, 2022. Today is a case list defense webinar. Before we start, I just want to see if anybody has any questions about anything. I know we only have a few more weeks left before the exam. Just going to look down the line here. So I don't see anybody with any questions. Does anybody want to be part of the hot seat? We have a small group today, so if you have not been on the hot seat, please raise your hand so you can have that opportunity. Carolyn, I'm going in your direction. It says you're self-muted.
Hi.
Hey, how we doing?
Good. How are you?
Awesome. Are you a generalist or subspecialist?
I'm a generalist.
Okay, awesome. Are you looking for a question out of your specific case on one of your lists, topic? What are you looking for?
I don't have a particular list or case in mind. Happy to go with any of them.
So you want something from a list, any specific list?
Nope, happy to go any direction.
All righty, let me see. Too much pressure for me to pick. So the screen is black, right? Am I correct? The screen is black?
It just says live oral. Yeah.
It's blank. Yeah, okay, so let me look for your list here. A good size OB list. Just looking for a case.
No worries.
Case number 64.
Okay.
So what's a splenic thromboembolic infarction? What happened there?
Sure. So this patient, prior to me being involved with her care, my understanding was before she was pregnant in her early 20s, she was diagnosed with a splenic thromboembolic infarct. It was considered unprovoked, and she had thrombophiliia workup as well as a antiphospholipid workup that were both negative. She had stopped anticoagulation by the time that she was pregnant, though.
So they have any idea how that occurred?
No, there was no.
She was on like birth control pills or anything like that?
No.
Interesting.
Yeah.
What can you tell me? Yeah, go ahead.
No, it was an unusual scenario.
Yeah. Now, the anticoagulation that she was on, was that because of her history of the splenic infarction or for the septic pelvic thrombophlebitis?
So she was on prophylactic anticoagulation in the interpartum setting for the history of splenic thromboembolic infarction in the past. And then when she was diagnosed with septic pelvic thrombophlebitis, we started her on adjusted dose anticoagulation postpartum.
So describe what happened in regards to the septic pelvic thrombophlebitis.
Sure. So after her C-section, she had a rest of cervical dilation, and she hadn't had an exceptionally prolonged period of rupture of membranes, but because she had, had rupture of membranes prior to the
So let me
C-section.
ask you this, what's a prolonged amount of time?
Um, for certain criteria, like choosing when to start GBS prophylaxis, a prolonged period might be considered 12 hours. In her setting, it was only a couple hours that she'd had rupture of membranes. But even in that setting, the initial presumed diagnosis
So
was.
let me interject here. You said she was ruptured only for a couple of hours. So how did you diagnose her arrest of dilation?
So she had an IUPC in place that showed she was having inadequate contractions, and she had arrestive cervical dilation for more than 6 hours.
So what's the definition of inadequate contractions?
Adequate contractions would be over a 10-minute period, an IUPC measuring more than 200 Montevideo units.
And so she ruptured for a couple of hours, but yet after she ruptured, when did you call the section?
She had, I believe she was six centimeters, and she'd been 6 centimeters for more than 6 hours.
And how long has she been ruptured during those 6 centimeters?
I couldn't recall the exact number of hours. Certainly a significant period of time, though.
You just said she was ruptured only a couple of hours. So you just said initially.
Mm-hmm.
So it's more than a couple of hours. Am I correct?
I would have to review this patient's chart to know how many hours she was ruptured.
So let me ask you this. If somebody's ruptured for 2 hours, you would just
Mm-hmm.
call her, even though her Montevideo units might have been at the appropriate level, you would call her arrest? Or you would give her some more time?
If a patient had adequate contractions with detected by IUPC and it had been more than 4 hours, I would still diagnose the patient with arrestive dilation.
Even though she may have been ruptured only 2 hours of those 4?
Yes. I mean, I think there are scenarios where we can decide to give the patient more time, but my understanding is that she would still meet the diagnosis of arrestive dilation.
Now continue with your discussion of the septic pelvic thrombophlebitis.
Sure. So in this patient, she initially was presumed to have endometritis, and she was
So
started on.
How did you treat her for the endometritis?
She was on ampicillin, gentamicin, and clindamycin.
So can you tell me why you started those antibiotics? What were you treating?
So we were covering both anaerobes and aerobic.
Yeah, exactly. What antibiotic covered what?
Okay, so clindamycin is covering anaerobes. Ampicillin is covering gram-positive bacteria, and gentamicin would be covering gram-negative rods.
And how do you diagnose the endometritis?
She had some mild fundal tenderness, and she was febrile.
Okay, continue with your discussion of the SPT.
So she continued to have fevers through the initial broad spectrum antibiotics, and so then she was then brought into piperacillin and tazobactam, and infectious disease was consulted.
So why was she switched to those antibiotics?
That it was in conjunction, it was based on a recommendation from infectious disease. I am not sure which additional bacteria we would be covering with a broader regimen.
Okay, continue.
She actually continued to be febrile with Piperacillin tazobactam, and in that setting, she ended up having a CT chest, abdomen, and pelvis, as well as an ultrasound.
Why of the chest?
Sorry?
Why the CT of the chest?
To rule out pneumonia. At that point, we
Is there a
didn't
different way you can rule out a pneumonia that's cheaper?
chest X-ray. She had also had a chest X-ray earlier in her course.
Did it show she had a pneumonia?
No.
Okay, continue.
And all of her imaging was unremarkable. And in that setting, hematology was also consulted, and
So why was hematology consulted?
to discuss the potential diagnosis of septic pelvic thrombophlebitis.
So how's that diagnosed?
My understanding is it's a diagnosis of exclusion for a patient who continues to be febrile, and really the only way to confirm the diagnosis is to start on anticoagulation to see if she depresses with the anticoagulation.
And did she?
She did, yeah.
Now, were the antibiotics continued?
Initially, they were.
And when were they discontinued?
She completed, I believe she actually completed a 6-week course of Augmentin with her adjusted dose anticoagulation.
And she was continued with the anticoagulation for 6 weeks as well?
Correct, yes.
Now, if she did not have this history of the infarction, would they have continued? Would she have been treated for the 6 weeks as well?
I believe so.
Okay, let's stop there.
Have to.
You're gonna say, I didn't mean to cut you off. Go ahead.
No, I was just saying I would definitely have to review that with a hematologist.
All righty, let's stop there. What do you think?
Anticoagulation is hard for me always. This is just kind of a weird.
But I think what you said everything very nicely about SBT. It is a diagnosis of exclusion. You're supposed to continue the antibiotics. Now, when I was a resident, you would treat for the 6 weeks. Apparently, you don't say studies. I'm not an MFM. Don't pretend to be one. Apparently, some experts are of the opinion that you don't have to treat for that longer a period of time.
Okay.
Again, I would touch base with my hematologist to see, because this is the how you manage your patient. What was the thought process behind that?
Right.
In her case, she needed prophylactic anticoagulation, right? Because of her history.
Yeah.
Right. So you just, adjusted it, of course, appropriately. I would find out why they switched to antibiotics, because you had pretty good broad spectrum coverage, right? You got to know what antibiotics and why they were started. So your AMP is for gram positives, GENT for gram negatives, and your Clindas for the anaerobes. Okay, so that was all very good. Now, chest CT, I don't know. That seems, well, you said pelvis imaging. Was it CT? I just assumed it was a CT.
We did a CT.
I think that's overkill of the chest. Not saying not of, because sometimes you could see the clot, and if you see that on the CT scan, which is not common, you have your diagnosis as well. But it is a diagnosis of exclusion, especially if there's nothing on any of your testing. I'm sure she got blood cultures and all that good stuff, right?
She got
The
tons of
$4 million
blood
workup. Yeah. I think the chest CT might have been overkill unless you were looking for a PE or something like that. But you would do a CTA or spiral CT or whatever they call it nowadays.
Yeah, I'll have to look and see.
actually ordered?
I don't know the answer in the sense, I think if she was ruptured only 2 hours and then you just called her 4 hours later that she's arrested, I don't know. I don't know if I think I would give her more time.
Mm-hmm.
You
Mm-hmm.
know, I wasn't there. So I would look into probably she was ruptured for a longer period of time.
Mm-hmm. Mm-hmm.
You know what I'm saying?
Yeah.
And realistically, why would you rupture a patient and you can check her 2 hours later? She hasn't really changed much. Okay, I'll put an IUPC. She has the Montevideo units. I would have given her more time, but that's just my opinion. Again, I
Mm-hmm.
wasn't there. But that's the one thing that you said that was kind of, so that's why I pounced on it. And you
Okay.
see, a lot of the stuff that you said, I mean, I wasn't going to ask you about chest CT, but you said that, and I'm like, oh, okay, let me ask. So it's what you say sometimes comes back to haunt you sometimes.
Mm-hmm.
No, but I
Mm-hmm.
think overall you did well.
Thank you. Thanks. Thank you so
Questions?
much. This is really helpful.
Yeah, no worries. And I would look more into the splenic thromboembolic infarction. Poor lady. I don't know how that happens. Okay. Anything else?
No, thank you so much.
All right. Very good. Thank you. All right. Anybody else want to be part of the heart seat? I got a couple other candidates here. Jennifer, I'm going in your direction. You there,
Hi.
Jennifer?
Yes, hi.
Hi, how we doing? How's it going?
Good, good. Studying all the
All
time.
right. I know everybody is, right?
Yeah.
Generalist?
Yes.
Okay. A specific case, specific list, what you looking for?
Maybe something off office, no specific
Okay.
case, whatever
Okay,
stands
let's
out to
look
you.
for it. All right. The hardest part is finding the list. Takes
Yeah.
forever. I'm just looking.
Okay.
Case number 21.
All right.
What are signs of lidocaine toxicity?
Lidocaine toxicity. Signs include ringing in the ears, metallic taste, kind of depressed respirations. And then as you have a higher toxicity, you get concerned about respiratory and cardiac arrest.
And what is the reversal agent of lidocaine?
I don't believe there is a reversal agent.
So what is the maximum dose of 1% lidocaine without epinephrine?
Without epinephrine, 4 milligrams per kilogram.
I'm sorry, say again?
For without epinephrine, 4 milligrams or milliliters per kilogram, sorry. Sorry,
And then with epi.
it's my dog. With epinephrine, it's 7 mg per kg.
Now, let's say you're doing this biopsy in your office and the patient starts complaining of some perioral tingling. What would you do?
I would stop injecting the lidocaine and observe the patient, get a set of vitals, and then observe.
And let's say the patient is tachycardic, blood pressure's on the lower side. What would you do?
If I have the capabilities in my office, which I don't in real life, to get an EKG, I would do that. And then I would also raise her legs up as well.
Anything else you would do?
I would, ask her more about her symptoms, make sure that she's alert and oriented, and then repeat her blood pressures and heart rate.
Let's say things really are not changing, doesn't look good.
So at that point, if she's still hypotensive and tachycardic, then I would arrange transportation to the hospital.
How would you do that?
By calling EMS and having her transported by ambulance.
Now, can you tell me what the pathology or histology of lichen sclerosis is?
Sure. So on histology, you'll see kind of loss of the reedy pigs.
Anything else?
Since it's in the vulvar area, you also see keratin, but that's really kind of the pathologic finding.
And describe for me how you educate the patient in regards to lichen sclerosis.
Right. So I would explain to the patient that lichen sclerosis doesn't have really kind of a formal cause. It's kind of a chronic condition that causes a lot of vulvar itching, a lot of potentially dyspareunia as well. It's treated with a high-dose steroid cream that can be used indefinitely because the risk of potential progression to malignancy is about 5%. So it's really important to treat it and for close follow-up.
Now, how do you tell her how to use the steroid?
Right. So initially, I would have her apply the steroid cream to her vulva nightly, and then you can do that for 4 weeks. And I would have follow up after that point to assess her symptoms and do a
So let's say
publication.
she's improved.
Mm-hmm. So at that
How
point,
would you instruct her?
right. So at that point, if she's improved, we can kind of space out the usage of the clobetasol to about every other day for another 4 weeks. And make sure that she's stable on that regimen.
And let's say the patient's going to be on it for long term, she's improving. How would you instruct her on a long-term use of the steroid ointment?
So ultimately, I'm hoping to get her down to just twice a week if her symptoms are maintained on that suppressive dose. And then again, continue to have close follow-up and counsel the patient about also being aware of what her vulva looks like and if there's any progression or new lesions, at which point she should make an appointment so that I can evaluate those lesions.
And you would follow her how often once she's on a good regimen that's controlling her symptoms long term?
Right. So at least every several months, so maybe every 3 months, I think would be reasonable as long as her symptoms are stable with no new lesions.
And why can't you use the steroid cream daily, indefinitely?
Right. So because of how potent this steroid cream is, it can be very irritating to the vulva. So it kind of counteracts, or even can cause a lot of the symptoms that she initially presented with if it was like vaginal irritation, vulvar irritation.
Can you tell me what lichen simplex chronicus is?
Right, so that is also a chronic condition of kind of repetitive itching. It causes excoriations. It can have or be associated with like an underlying allergy that patients may have. It's also treated with steroid cream as well. But my understanding is that it doesn't have an association with malignancy like lichen sclerosis does.
So is lichen sclerosis a scarring or non-scarring process?
Lichen sclerosis, I would imagine, is a scarring process.
And what about lichen simplex chronicus?
I I would say that that's also a scarring process.
Now, can you tell me the different types of BIN that exist?
Sure. So there's low grade and high grade for VIN, or usual
What if I
type,
told you?
non-usual type.
Okay, so what's usual type?
So usual type is associated with HPV virus.
And what's the other type?
Not associated with HPV, so things like lichen sclerosis.
And what's it named?
Oh, is it non-usual type?
It's differentiated.
Differentiated.
All right, let's stop there. What'd you think? Very nice.
Sorry, my dog's playing in the background, so I was a little distracted.
No worries.
Yeah, I was kind of thrown with a lidocaine because I didn't see that I put that anywhere on the list, and then
Well, you wrote vulvar biopsy.
Right. I
That's why I brought it up.
realized that's where you were going with that.
No, just to, put a couple of topics in there. So everything
Totally.
you said about the lidocaine toxicity was correct. Didn't see any error there. I mean, the issue with lidocaine is the patients can decompensate pretty quickly.
Mhm.
So you really have to be on top of it.
Right.
There
There is
is no reversal agent. Say again?
Yeah, I was just going to ask about the reversal.
Yeah, there is no reversal agent. It's kind of a trick question. However, you could use some fat emulsive and hopefully in an IV type of therapy, and apparently hopefully it binds. But
Hmm.
again, there is no reversal, so that's why it's very concerning to kind of pay attention. I remember as a resident, the patient would be complaining of that, and you're like, oh, you just kept on going. By luck, nothing bad happened, by luck.
Yeah.
The maximum dose without epi is 4 mg per kg. With epi is usually higher, 7 mg per kg. Okay, and I thought, at some point they're gonna make you call EMS, whatever, in any of these type of scenarios. In regards to the pathology or histology of lichen sclerosis, it's a thin epidermis, hyperkeratosis, and again, the decrease in the red pegs. Usual type BIN is HPV related, differentiated, is dermatological. Okay. Lichen simplex chronicus is a non-scarring process. It's kind of, for lack, like an atopic dermatitis of the vulva. So once you treat it, it resolves. And you really shouldn't have, but people that are more prone to like eczema, asthma, those type, they could be more prone to the lichen simplex chronicus. Okay. To my understanding, the risk of squamous cell carcinoma with the lichens is 2 to 5%, and it's high. It's high untreated. So apparently, that's the new practice bulletin says if you treat it, it decreases the risk of malignancy. However, they still say 2 to 5%.
Okay.
My interpretation of what I read. Okay. Any other questions?
Was my regimen okay with kind of doing 4 weeks of nightly and then 4 weeks?
Yeah, you'd want to taper off, because in the end, if you give steroids on a daily basis, you're going to thin the skin or the tissue, and she's going to get symptoms because of the treatment, for lack of a better word.
Yeah.
You want to avoid that, so to speak. No, but I think it was, I think everybody's answering the questions awesome, very well, but you have the exam just around the corner, so that's awesome. You guys are so, in the beginning of the season, you tell somebody what's the maximum dose of lidocaine, they're like, I don't know.
Yeah.
But now that it's crunch time, exam's just around the corner, and at this point, all of you are going to be taking the exam at the same time. There's nobody that it's taking it next month, so everybody's going to be really well prepared. So great job.
Thank you. Appreciate it.
Okay. Other questions?
That was all. Thank you.
All right. Very good. Thank you. All righty. See if anybody else wants to be on the hot seat here. Ruth, I'm going in your direction. It says you're self-muted. You there, Ruth?
Yes. Can you hear me?
Hi, how we doing?
Good, how are you?
Very good, very good. Remind me, are you a generalist?
Yes, journalist.
Yes. Okay. Are you looking for something specifically?
No, I would say, well, since we just did office, probably just gynecology, or actually
Okay.
urogynecology. That's one of my weak
Okay.
spots still.
Did you turn in your list? I don't see it here.
It might be in the October.
October. Check it out.
Oh, and actually, my last name is wrong. It would be under Claros, Claros.
Maybe that's the problem. Let's see. I got it.
Okay, perfect. I
Yeah,
guess
if you
not
hadn't
wrong.
said it,
It's
I
my
wouldn't have
married
known.
name. Guess I
I
shouldn't
wouldn't
say
have not
wrong. It's my
known.
married. Yeah.
Would have not known that. Okay. All righty. So urogynecology. The pressure.
Yeah, I don't think I have a lot of urogyn on my
You don't have
list.
anything there? So can I just make something up?
Yeah.
Okay, let me see what I got here. Hold on, let me see. Case number 24. Okay.
Okay.
Could this procedure have been performed as a TVH? Why or why not?
So this patient actually had a history of four, or actually three prior cesarean sections. So I did not feel like she was a good candidate for a vaginal hysterectomy because of that reason.
Okay. Now, was anything done in this case in order to suspend or to suspend the vagina or the vaginal wall?
Yes. Yeah, so usually what I do is I incorporate my uterosacral ligaments into the apices of my vaginal cuff.
Can you describe or dictate how you do that?
So as I'm throwing my, so I usually close the vaginal cuff using a running barbed suture. And so I always, as I'm throwing the suture through the posterior or to the inferior side of the cuff, then I always make sure that I'm just throwing the suture also through the uterosacral ligament on that side.
And then
And
you do
that's
it
how I
on the other
incorporate
side.
it.
And you do
Yes.
it on the other side as well.
Mhm.
So let's say the patient has apical prolapse. I understand you personally may not do these procedures, but what
Mhm.
surgical procedures are available in order to treat this?
So I would say there's, if I remember correctly, the gold standard would be a sacrocolpopexy. But then there's also a uterosacral ligament suspension as well as a sacrospinous ligament fixation.
Can you tell me pros and cons of a abdominal sacrocolpoplexy?
Well, I would say the pro of an abdominal sacrocolpopexy would be that it is thought to last a lot longer. And then the con of that would be that you're using mesh. And I guess another con would be that a lot of times you do a supracervical hysterectomy, and by leaving the cervix in place, sometimes you could get into like bleeding afterwards, like postcoital bleeding.
Now, do you have to leave the cervical stump?
I was under the impression that you do, because it's a much better support for the mesh, and that's all, the ones I've seen always left the cervix in place.
Now, where do they attach the mesh to? On the other side, not on the you know, for lack of a better word, the vaginal side, the body side, for lack of a better word.
I would say they attach it to, they tunnel it through the peritoneum and they attach it. I would say by the sacrum, but I'm blanking on the actual where they attach it to.
Now, is there any concerns for any vascularity or nerves in that area?
There is. So there is, I believe it's the middle sacral or the lateral sacral artery. That would be a concern in that area.
Can you tell me pros and cons of the sacrospinous ligament fixation?
That procedure I'm not as familiar with, but I would say the pro would be that you're using, I know it's a native tissue repair, so you're not using any mesh. I would say the cons is that you can get into, there's a high risk of injuring the pudendal nerve.
Anything else?
I would say because I believe you only perform it on one side. No, I think that's it. I would be guessing if I continue.
Okay. Now, what has a greater risk of cup dehiscence, a TLH or robotic TLH in this case, or a TBH, and why?
So usually it's, I would say robotic or TLH, because one of the reasons is the magnification. And so you oftentimes can think that you're taking a bigger bite of the vagina than you actually are, as well as the cautery that is used can make it so that, you know, tissue is not as vascularized and doesn't heal as well.
Now, can you tell me any prophylactic procedures to assist in preventing vaginal vault prolapse?
Prophylactic procedures. I would say besides just modifiable risk factors, like things that would
A cervical procedure. So let's say I did a vaginal hysterectomy. Is there a procedure I can do that will prophylactically, hopefully, prevent?
I mean, I would say other than
vault
incorporating the utosacral ligament suspension, or other than incorporating utosacrals, I'm not aware of anything, unless you did a procedure at the time of your hysterectomy.
Right. So I did the TVH. What procedure would you be thinking of?
Are you referring to like a McCall's?
Yes.
Okay.
So how do you do a McCall?
From what I think you're just also just incorporating the utosacral ligament into the vaginal cuff.
Can you go through the steps through it? Let me ask you this. What happens to the uterosacrals in a McCall? How are they tied?
I would have to look that up to see what specifically happens.
How about with the uterosacral ligament suspension? What happens to the uterosacrals?
Oh man, I asked for this.
You asked for it. You asked for it. You got it. Is that a cigarette commercial or something?
I don't know.
As I let you struggle a little bit more, I'm going to look for some pictures. So see if I can explain it to you, but struggle a little bit more.
Okay. I'm trying to think back to when I watched them in residency. And I could not say anything besides they got incorporated into the cuff.
But you couldn't tell how it got.
Mhm.
How many uterosacral ligament suspensions did you see in residency?
I would say probably just a few.
Okay.
Yeah, it wasn't
And
very
what about a
many.
McCall? So let me ask you this: with a McCall,
Mhm.
what could be most likely injured?
The ureter.
Okay. What about the uterosacral ligament suspension?
I would say you're also worried about the ureter in that for the suspension as well.
Correct. I'm here looking for it, but I'm missing it, so I can show you. Hello. So give me a second here.
Mhm.
There we go. Give me a second, guys, because I didn't anticipate this, but you need to see the pictures. If not, you're not going to get it. I don't think you would. I could be wrong. All right, let's go over it.
Okay.
So, interesting with the presentation of the case, you should have put in her diagnostic area the C-section times 4 or times 3,
Okay.
because they're
Times
going to
three.
ask you that. And that's why they ask you for the weight of the uterus, because they're going to go, why'd she do that robotically? Why'd she do it with TLH? I mean, your answer was appropriate, but you could have avoided
Mhm.
that. And it could be an easy answer, right? Easy question, easy
Mhm.
answer. So I just noticed that. I mean, what you said was correct, but they would not have asked you that question if you had put the C-section times 3. And some people would consider that as a diagnostic point to include.
I see. Okay.
Makes sense? Yeah, because that's why they want the weight. If it's a small uterus, why didn't you take it out vaginally?
Okay.
And I could have easily asked you to dictate a TBH. Would you have been
Okay.
able to do that for me?
I hope so, because you asked me to dictate it the first time and I royally screwed
I
it up.
did?
So.
Okay,
Yeah.
okay. Dude, sorry, I don't remember. But that was many months ago, right?
Yes, it was.
I haven't asked that question in a long time. And it's funny because I've been during the mock orals, people are like, well, you guys kind of repeat the same topics over and over again. And I'm like, yes, repetition is good. And then after the mock oral, I'm like, you got to repeat it even more. But you know what I'm saying? So
Yes, no, it is.
there's only a certain number of topics. So yeah. So what else did I ask you? TLH versus or robotic TLH versus TVH. You're correct. It is the robotic or the TLH because of the cautery, usually because it causes tissue necrosis. Magnification makes you think you got some good bites. You did not. Also, you think you got some good bites when you're suturing through the laparoscopic instruments, and it's usually better with the instruments that are in your hand are less lengthy, for lack of a better word. So the abdominal sacrocolpoplexy, you attach it to the anterior longitudinal ligament.
Okay.
Middle sacral arteries, what could bleed. There's really no nerves that can be injured. Now, be careful. I know newer, I guess, urogynecologists that are more recently trained, they do leave the cervical stump. They feel that's a better area to like attach the mesh to avoid erosion. But you can do it vaginally because that's the way I trained. It was done vaginally. We never left the cervix behind. Okay. And that is the gold standard. It is anatomically correct, so it has the better success rate. The SSF, it is anatomically incorrect. It deviates it to the patient's right because you have the sigmoid colon on the other side. Some providers, very rare, they would do it bilateral.
Okay.
And you don't use mesh. You use a permanent suture. Both these procedures, you have to have experience in them. And the thing with the both can cause bleeding. Of course, the middle sacral artery, the prevenous plexus, those type of things. You could put bone wax, thumbtacks. stuff to stop the bleeding. So you could bleed a lot there with the, that's with the abdominal sacrocolpoplexy. With the SSF, the pudendal branches of the pudendal artery can be injured, the pudendal nerve, the sciatic nerve can be injured. If the patient is complaining of significant gluteal pain in the recovery room, you have to go back and remove that suture because you bagged the sciatic nerve.
Okay.
The uterosacral ligament suspension could be prophylactic, and or it could be for treatment. The McCall is only prophylactic. So the McCall actually plicates the uterosacrals in the midline. Anatomically incorrect.
Okay, that's what you were looking for, was a plication. Yep. Okay.
So I was like, what happens to the uterosacral? Where do they go? It's hard to explain. So you would start with your vagina. Let's see if I go with the next suture here in this picture. So here's your vagina. So you go through. Here's my uterosacral. I go through it, right? See how I went through? Then I refit through the posterior peritoneum, go through the uterosacrals, go through the vagina. Tag it. Now you go up. You're past the vagina. You grab the uterosacral. You can get the ureter by accident. Grab the uterosacral. Refit. Come out the uterosacral on the other side. Tag it. You can go up a third time. Okay?
Okay.
So it plicates in the midline. Oops, wrong way. So these will pull in the midline. Do you see it?
Yeah, no, thank you. The picture was really helpful. I don't think I would have gotten it without the picture.
So you need to do a cystoscopy with either a McCall or a uterosacral ligament suspension because you could damage the ureter. That's a must. Here's the uterosacral ligament suspension. It does not plicate in the midline, right? It's actually to the ipsilateral, lack of a better word, cuff. I've never done one of these, but talking to urogynecologists, they'll go all the way to the spine, the ischial spine. That's pretty high up there. And they're like, it's not as hard as you think. I'm like, okay. Again, I've never seen that. It took me a while to find this picture. So this is prophylactic and treatment. Okay. While the ones we talked before, the abdominal sacrocolpoplexy, the SSF, that's treatment. Okay? Completely different. So be careful with the words of prophylaxis and treatment. Okay?
Okay.
So questions on that?
No, thank you. That's what I needed to review.
You good? You're good with that?
Mm-hmm.
All right. Let me see if anybody has any questions, because yeah, that's why I wanted to get these pictures, because I can just explain. You'll be like, I don't know what she's talking about. And I guess it makes it easier if you understand. It makes the explanation better, and you can discuss it better with the exam. I got a question right here. Can you explain the McCall one more time? Yes, we can. Hold on. Okay, so you go through here's the external McCall suture. So I go through the vagina. I have the uterosacral with an Alice. I grab it with an Alice. I go through the uterosacral through the inner part of the vagina. Then I reef. I don't go all the way through the vagina. I reef the suture through the posterior peritoneum because I need to, bring it to the other side. Go through the uterosacral on the other side. Come out the vagina here. And you tag it. Now I'm beyond the vagina. So I just grab the uterosacral, which will be up here. Kind of see it? I reef it through, come out the uterosacral, tag it. And then you do it a third time. Grab that uterosacral, reef it through the posterior peritoneum, go out the other uterosacral, tag it. So when you close the cuff, you tie everything at the end. And it's supposed to cinch everything in the midline. This would push in. Do you see? Here's my vagina here. My vagina's closed, right? The vault. I do the first suture through the vagina, but then I do the other ones higher up because I'm beyond the vagina, and then all this ties together and you plicate in the midline. So hopefully that explains it. You're still there, Ruth, or you're off the call? She's off the call, so I'm assuming she had all her questions. You're good? You have all your questions answered? You're good? Good job.
Yes, thank you.
Very nice. I'm gonna go to my namesake here, Zoe. Are you there, Zoe?
Yes, I'm here. Hi.
How you doing? How's it going? From
It's
one Zoe to
going.
another, right?
Yes, yes.
Did that
Feeling
answer
in
your
good
question?
company. It did. It did. I've seen folks do like a modified McCall's with just 2 sutures as opposed to 3. So that was helpful.
Right. Yeah. I know. I mean, some people ask me what's the modification. I don't know. I mean, everybody has different modifications of things, right?
Yeah.
Okay, so let me close this up. You needed to see the pictures.
Yeah. Thank you.
Okay. So let's go. Okay, are you looking for something specific?
Just anything off of the OB list.
Case? OB, okay.
Yeah.
I'm sorry, you're a specialist or what are you?
No, I'm a generalist.
Oh, you're a generalist. Okay.
Mm-hmm.
Okay, perfect. So OB. Okay, let's take a look. I'm just looking. Okay, bear with me.
Mm-hmm.
Case number 25.
25. Okay.
Can you tell me other causes of thrombocytopenia?
So other causes of thrombocytopenia in pregnancy, other than gestational thrombocytopenia, can include TTB, thrombocytopenic thrombotic purpura, hemolytic uremic syndrome, HUS, certainly hypertensive disorders of pregnancy, specifically preclinical with severe features, or HELP syndrome can also be causes of thrombocytopenia. If a patient is on anticoagulation, heparin-induced thrombocytopenia or HIT.
Anything else?
Those are the things that come to mind for me initially.
So what is ITP?
So ITP, which is immune-mediated thrombocytopenia, is also.
I'm sorry, you're breaking up. Are you there?
Oh, I am. Can you hear me?
Okay, can you repeat that one more time? I'm so sorry. You broke up big time.
Yes. Sorry, I'll try to go to a better area. So ITP is immune-mediated thrombocytopenia, and it's another cause of thrombocytopenia in pregnancy.
And so I know it's immune mediated. What do you mean by that?
So it is an autoimmune condition, which is the cause of the thrombocytopenia.
And what's the specific issue?
The specific issue is that the patient has created antibodies, antiplatelet antibodies causing destruction of platelets and therefore thrombocytopenia.
So how is it treated in pregnancy?
So this is not something I've reviewed, but so treatment of ITP in pregnancy can include anti-inflammatory medications like steroids in order to mute the autoimmune response of the antiplatelet antibodies.
Anything else you could treat with? Did I lose you? Or you're still there?
I'm still here, sorry.
Still there? Okay, I just want to make sure.
Quietly thinking. Certainly if a patient had low enough platelets, you could consider a platelet transfusion, but given that it's an
So
autoimmune process.
what's a low enough platelet count? When
So
would you get concerned in your practice that somebody would need a platelet transfusion?
I would be concerned at platelets less than 50,000.
And is that dependent on route of delivery?
I'm sorry, I couldn't hear you. Was that dependent on?
What's that dependent on route of delivery? It'd just be 50,000 for either a C-section or a vaginal delivery, or not necessarily?
That would be my threshold for either a C-section or a vaginal
Okay.
delivery.
Okay. So let's say you had to transfuse a patient. How would you transfuse her? How much would her platelet count go up depending on how you transfuse her? Can you explain that to me? Am I making sense?
Yes. So with a unit of platelets, I would expect an increase of about 10,000 with the patient's platelet count.
What do you mean by a unit?
Or a pack of platelets.
How much is a pack of platelets?
I believe a pack of platelets is 5 units.
Okay. So it would go up 10,000?
Yes.
And when would you transfuse the patient? I know you said at 50,000.
Mm-hmm.
Before, let's say before a C-section, would you do it an hour in the PACU before she goes to the back?
So if I
had
had
time to transfuse her,
the best time to transfuse the patient would be preoperatively. I would say
how early
within,
preoperatively?
I would say at least 3 hours preoperatively.
Anything else you could give her management-wise medication?
Yes, you
Let's
could
say
give.
you want to transfuse her, not quite yet.
Yeah, you could give IVIG as another treatment for ITP.
Now, this patient was at elective induction of labor.
Mm-hmm.
Okay, what was her Bishop score? Well, let me ask you this: what is a Bishop score?
So a Bishop score is a calculation of favorability of the cervix based on dilation, effacement, station, and consistency of the cervix, as well as position.
What score are you looking for?
I'm looking for a score of, a favorable score would be a score of 6 or above in a multiparous patient, or 8 or above in a nulliparous patient.
So let's say you have a patient with a Bishop score of 10. What does that actually tell you?
That tells me that their cervix is very favorable and that their likelihood of a successful induction of labor is high.
In comparison to what?
In comparison to a person with a lower Bishop score.
Can I give you an exam and you tell me the Bishop score?
Ooh, I can try.
All right, 2 centimeters dilated, 70% effaced, -2 station, medium consistency, posterior position.
So can you write that down for me one more time?
270 -2, medium consistency, posterior position.
So 270 -2, medium consistency. I believe that's a Bishop score of 5.
Okay. One last question. What is ROGAM?
So ROGAM is RH immunoglobulin.
What's its mechanism of action?
Its mechanism of action is to bind up, let me think about this. So it's to bind up any innate antibodies made against Rh negative antigen.
All right, you can stop there. What'd you think?
That was my first mock experience of the season, and that was tough.
You did good. I could tell you somebody took this exam a couple of weeks ago. They got asked, they had gestational thrombocytopenia, and they asked them ITP.
Okay, I'm definitely going to review
Switch
those.
it up. They're gonna switch. In the end, I think, I mean, the more stuff you know, I mean, the I always say luck is involved. So the more you know, the luckier you'll be.
Yeah.
So because there's two types, I always say there's two type of examiners. One looks at your case list and asks you specific questions. Why'd you do that hysterectomy that route?
Mm-hmm.
Others, they look at your list and they just come up with topics.
Yeah.
And lately I've heard they've been doing more of the topics.
Got it.
So
Okay.
immune thrombocytopenia purpura is an acquired thrombocytopenia caused by autoantibodies against platelet antigens. Other causes of thrombocytopenia, you had a very nice list: drug-induced, chronic liver disease, hypersplenism, bone marrow suppression, infection, from an infection. So ITP in pregnancy, glucocorticoids or IV immune globulin roughly 1 week prior to scheduled delivery, because that works the best, especially the IV immune globulin, to my understanding. If platelet count is less than 30,000 for a vaginal delivery and 50,000 for a C-section, you should get a platelet transfusion. Okay, so to my understanding, a pack of platelets is 6 units, and really the platelets get used up pretty quickly. So 3 hours, the platelets would have been very, yeah. So realistically, the recommendation is, as the patient is on the table and you're starting to cut, so to speak, like a couple of minutes before, because a pack or 6 units increases your platelet count to 30,000. So it's 5,000 per unit. So a pack is 30,000 within 10 minutes of infusion.
So 1 pack is 30,000 because it's 5 per unit. Okay, got it.
5, yeah. That's 5,000 per unit, which there's 6 units in a pack.
Got it.
That's
Okay.
according to up to date. I'm not an expert in that. In regards to the Bishop score, I think the simplest thing, and this is what I've come to know and I've seen written, is if you have a score greater than 8, the likelihood of a vaginal delivery is similar to that if the patient presented to spontaneous labor. Yes, her induction will be easier, but she'll be more successful. And you were correct. It was a Bishop score of 5. So you got 1 point per 2 centimeters. 70% got 2 points. -2 got 1 point. Medium consistency 1 point. Posterior got 0. So that was a 5. So ROGAM, mechanism of action. This is according to up to date. I've never really thought about it, but it makes sense, I guess. Prevents isoimmunization by suppressing the immune response of antibody formation by RHD negative individuals to RHD positive red cells. When administered within 72 hours of full-term delivery, the incidence of RH isoimmunization decreases from 12% to 1%. Okay.
So again, that was that its mechanism of action is it's suppressing antibody formation. Is that right?
Mm-hmm.
Okay.
That's why you test for the antibodies, right?
Right.
Yeah. Now, they still, to my understanding, I've not looked this up, But I know years ago, they actually, I don't know if they have their synthetic ROGAM anymore, but they used to get the ROGAM from donors and they would irradiate it. So there's been no documented case of HIV or any bloodborne pathogen through ROGAM because of the irradiation. You don't affect the ROGAM itself. And because of it, again, I don't know if that's changed. Some Jehovah's Witnesses will not accept ROGAM because it's a blood product.
Mm-hmm.
Make sense?
Makes
Again,
sense.
I'd have to double check that. I don't know if that has since changed,
Gotcha.
but I don't think so. But don't quote me on it. So other questions. Good job. See, you thought it through. Good job. You know, but that's what they make you do on the exam. Think things through. And there's
Yeah.
nothing wrong with saying, can you give me a couple of seconds? Let me think this through here a second, because they'll move on to something else. And if you feel that you know the answer, you know, you want to get as many points as you can.
Mm-hmm.
Okay.
Perfect. Thank you so much. This was great.
Other questions? You did great. Everybody's doing fantastic. I feel like I'm not challenging anybody. Oh goodness. Or maybe I am. Okay.
I felt challenged.
So there you go. So Elise is asking, when doing 1:1:1 massive transfusion, does a pack count as 1 or 6 in those calculations? To my understanding, it should be a, oh, you're kidding me here. I think it's a pack. I would have to check on that. I won't be honest with you. I don't know, Elise, because that's a lot. But if you want to increase it by 30, because I know once they thaw them out, you got to give them. It's like the patient may not need it, they'll still give it because they get thrown out. Ooh, I would have to check on that. I don't know on a massive transfusion protocol, Elise. I'm sorry. So Rita's asking, what is the MTP protocol? Usually it's a 1:1:1. So 1 pack of RBCs to 1 of FFP to 1 of the platelets. But I don't know. I never thought about the pack, or is it a unit? Because your unit will increase it by 5,000 only. I would suspect, I'm going to be honest with you. I would suspect it would just be a unit, but you'd have to double check that. That's just me, because that's a lot of platelets. And I know some hospitals, smaller hospitals, they don't carry platelets, so they're a hot commodity. You'd have to check on that. I do not know. I'm sorry. Because you think platelets 1:1:1, but you don't think if it's a unit or a pack. I'm suspecting it's going to be a unit, but I could be so wrong. Okay. And I know once they thaw them out, you got to give it to the patient because they get thrown out. You can't rethaw them, or excuse me, refreeze them. Okay. So I'm sorry that doesn't answer your question, Elise or Rita. So my apologies. So I know we're past time, but I got no problem doing one more if somebody wants to be part of the hot seat here. Trying to see here. Tatiana, I'm going in your direction. It says you're self-muted.
Hi, can you hear me?
Yeah. How you
Okay.
doing?
Good, good.
You're okay hanging out a little bit. We have the time, right?
Yeah,
Getting
that's
close
fine.
to the exam. But everybody's doing good. I'm not challenging anybody. I don't know. Maybe I am. I don't know. Generalist or subspecialist?
Generalist?
Okay. So what are you interested in getting tested? What section?
I'm open to any topic. Haven't been studying office as much, but
Want to do office?
if you want to go there.
And of course, everybody that sees your list sees something different, you know?
Mm-hmm.
Show somebody, they'll say, oh, what about this? What about that? I'm just looking. So case number 28. Can you give me a differential of a vulvar ulcer?
It could be herpes simplex virus.
So let me ask you this. What
mhm.
is the difference between primary HSV infection and a non-primary HSV infection?
I believe my understanding primary is their very first outbreak, symptomatic outbreak of the disease, and then non-primary would be a recurrent outbreak. They've had it before, and primary tends to be a little more severe clinically than recurrent outbreaks.
So give me another some more differentials.
A chancre or maybe like an inflamed follicular hair a folliculitis from a inflamed hair follicle.
Anything else? And what causes a chancre?
That is the primary syphilis, the manifestation of primary syphilis.
And what causes syphilis?
The bacteria Treponema pallidum.
Do you know what type of bacteria it is?
I think it's a spirochete. I want to say
Gram positive, negative, or anaerobe?
I want to say gram negative,
Okay.
but I'd have to double check.
Anything else in your differential?
Okay, so HSV chancre. Okay. Sebaceous cyst, epidermal cyst. Off the top of my head, that's all I can think of right now.
Nothing else?
Chancroid.
What causes chancroid?
I believe Haemophilus ducrei.
Okay. Anything else?
I think that's it. Or a cancerous lesion, or maybe even rarely, but melanoma.
Okay. Now, can you tell me the different stages of syphilis and its treatment?
The first stage will manifest with a painless chancre or lesion, and the treatment is 5 grams of penicillin G IM. And then secondary syphilis will manifest with macular papular lesions throughout the skin, in particular the palms of the hand. And there's early and, hold on, let me go back. There's like an early and a latent phase of secondary syphilis. Early as if it's known to have happened within the last 12 months, and then latent, unsure if it was in the last 12 months.
So what is latent syphilis?
So it's a patient may present, and with testing, she tested positive, but she can't recall when she acquired the disease.
Okay, continue.
And so usually those patients are treated with 3 doses of penicillin 1 week apart.
Which one gets treated with 3?
Latent secondary syphilis.
So secondary syphilis and latent syphilis. Okay, continue.
And then tertiary syphilis, I believe, is like a prolonged disease. I would have to double check that. And then there's neurosyphilis, where they manifest with neurological symptoms.
And how will you treat the neurosyphilis?
I would have to double check, but if I recall correctly, intrathecal treatment, intrathecal penicillin administration.
Now, if you were not pregnant, is there any other antibiotic that can be used for the treatment of syphilis?
I don't believe so. I believe they'd have to be referred to an infectious disease specialist for desensitization if allergic to penicillin.
Even if not pregnant?
Even if not pregnant, I think they can be treated. I think doxycycline, I'd have to double check, but it's typically an antibiotic contraindicated in pregnancy.
Any other antibiotic that can be used?
Not that I can think of.
Can you tell me the process, general overview of desensitization?
No, I can't.
All right, let's stop there.
Okay.
What'd you think?
I need to really review syphilis again, like
Syphilis,
clearly.
I know somebody who took the exam in October got asked about syphilis.
Uh-huh.
Yep,
Yeah.
syphilis has come back. Aren't we
Yeah.
lucky? All
Yeah.
right, vulvar ulcer. Okay, the difference between a primary HSV and non-primary HSV infection. This is very clearly delineated, and believe it or not, in the HSV and pregnancy practice bulletin. They spend like a good amount of paragraphs discussing it, and they do a very nice job. So primary HSV infection is the first infection you've ever had of any type of syphilis, excuse me, HSV 1 or 2, okay? Non-primary is you've had the exposure before, you have the antibodies in your blood, you get a new lesion, they culture it, and it's the other subtype. So it's a discordancy of what's in the blood compared to what's cultured in the new lesion. And recurrent,
Okay.
what's recurrent? Recurrence, the recurrence. So there's primary HSV, non-primary, and now recurrent. So there's 3 different types. Does that make sense?
Yeah. Yeah.
Okay. And you're not the only one that gets it confused, so that's why I brought it up. Primary syphilis, chancre, correct. It is a gram-negative rod, correct. Or excuse me, gram-negative organism. It's a spirochete, apologies. It's a gram-negative. There's lymph granuloma venereum, that's chlamydia L1, L2, L3, granuloma inguinale, Klebsiella granulomatus, chancroids, Haemophilus ducreyi, like you said. Don't forget your VIN. Don't forget cancer. You said melanoma. You brought up folliculitis. Excoriation. It could be a wide list. Okay, so syphilis. So your primary syphilis is the chancre. Okay, it's painless, and it's actually the entrance of the spirochete into the body. Roughly 4 to 8 weeks later, you can get secondary syphilis. So that's the maculopapular rash in the torso, palms and soles, condyloma lata, or you can get like flu-like symptoms. Latent syphilis is positive testing with no symptomatology, and that's broken up into early latent, which is less than a year, and late latent, which is more than a year. Then you have tertiary syphilis. That's 1 to 10 years after exposure. And that's the gummas, the vascular aneurysms, okay? Neurosyphilis is its own entity of syphilis. It has nothing it's not associated with tertiary syphilis. Of course, the longer you have it, you can get that neurosyphilis. But neurosyphilis can occur at any time during the infection of syphilis. And that's the tabes dorsalis, the Argyll-Robertson pupil, the neurological sequela, okay? Anything less than a year in duration. So that would be your primary, secondary, and your early latent syphilis is treated with benzathine penicillin G, 2.4 million units IM times 1 injection. Anything greater than a year, so late latent and tertiary syphilis, the same dosing, but 3 IM injections a week apart. And you're correct. neurosyphilis. I don't think it has to be intrathecal. I think it's aqueous IV, if I'm not mistaken. I think you have to be admitted to the ICU, if I'm not mistaken. Don't quote me on that. Okay,
Thank you.
that makes sense.
Yes.
So if you're not pregnant, you could treat with doxy. You could treat with erythromycin. Okay, it's preferred to do penicillin always. Now, if you're pregnant, you can't take doxy, and that specific erythromycin does not cross the placenta. So that's why you have to desensitize the patient. So to desensitize a patient, you have to confirm, of course, that she is allergic, and it's a bad allergy, of course. And then if that's confirmed, there's different ways of sensitizing somebody. The simplest way, to my understanding, I've never seen it done, is drinking different aliquots of penicillin, different grades. You could give it IV, you could give it IM, but it's easier to drink something, right? And then once you desensitize them, then you could treat them. Now, the question is, if you desensitize somebody, are they desensitized for life? Yes or no? Did I lose you? You're still there?
No, I think you are for life.
You are not.
Oh.
So to my understanding, because I actually did a mock oral on, there's actually, and I had heard of this fellowship. It's an infectious disease GYN fellowship in Charleston, South Carolina. So I did her mock oral a few years ago. So I asked her all these questions about syphilis. And she said that once you desensitize somebody, they would send them home on a small amount of oral penicillin. So that way, when she came back for her second injection and third, you wouldn't have to desensitize her again.
Okay.
However, during one of the mock orals, a gal had to desensitize somebody. So she said that for some reason, it had to be to the day. It couldn't be more than a week pass of the desensitization. If not, she'd have to desensitize it again. And of course, the critical care or the ICU people hate your guts because you're taking up a bed on a patient who luckily is not sick. You know what I'm saying?
Mm-hmm.
Compared to some of the patients that they do end up with, especially like in the time of COVID and all that stuff, right?
Yeah.
Okay. So questions on that? I think that's everything.
Yeah, thank you.
Okay. Makes sense?
Yes.
All right. Very good, Tatiana. All right. I'm going to see if anybody has any questions because at this point, we're going to wind things down. Okay. Here we have a question. Does primary, non-primary, recurrent, and recurrent matter outside of pregnancy? Ooh, or only during pregnancy given differences in transmission risks? I think primary, I never thought about it. I'm just thinking primary and non-primary with recurrent. Of course, recurrent's the best if you were pregnant, of course. That practice bulletin is to me very difficult because they're very wishy-washy. So they're of the theory that say you got a primary infection, I'm making this up, at 33 weeks, 32 weeks. They're very wishy-washy. They say that you they even recommend C-section, even though there's no lesions, because they feel the antibody, there's not been enough immunity during the pregnancy. So there's nothing wrong with doing just an elective section, even though she may not have any active lesions. And they even indicate, let's say, she had a, let's say, rupture of membranes with her first case ever of HSV with ruptured membranes. That practice bulletin, again, could go either way. You could deliver the patient right then and there, or you could treat, with latency antibiotics, antivirals and stuff like that, and then deliver her at 34 weeks. And I'm assuming at that point it would be a C-section because you'd still have some lesions there. So it's a very kind of not very clear. They kind of flip-flop on that specific practice bulletin, in my opinion. But I'm assuming that primary, non-primary, and recurrent are the same in and out of pregnancy. But you'd have to double check that. It just makes makes sense that it would be that way. So hopefully that answers your question, Jennifer. And I apologize to Elise and Rita that I don't have more on that MTP protocol in regards to the pack of platelets. So my apologies on that. You'd have to look that up because I just don't know. Any other questions before I let everybody off? I think everybody did great today. I appreciate everybody participating. I think people are answering questions excellently. I mean, I know there's only a few more weeks left before the exam, so I think everybody's in a good spot. So keep up the good work. Any other questions? Just checking down the line here. I don't see anybody putting anything in the box here. Just looking again. Okay, I don't see anything. I will stay on the call just a couple of minutes to see if anybody has any like questions pertaining just to them. I could send you a response privately. And I won't speak, just to type it in if you had any specific questions about anything. If it's very complicated, then I'll get you back on the call. But at this point, if nobody has any other questions, I'm gonna end the webinar at this point and wish everybody a good night, a good rest of the new week, and continued good studying. So take care, everybody, and have a good night. Thank you, and I'm gonna stay on if anybody has any questions for like a private message or for any questions about anything in regards to the exam. Okay, I thank you everybody for your attention and have a good night. Thank you.